Hello, colleagues. I'm Professor Subodh Verma from the University of Toronto, where I'm a cardiac surgeon at St. Michael's Hospital and also a professor of surgery and pharmacology. I'm really delighted to be here with you today to share with you a couple of highlights in the area of heart failure and cardiometabolic disease from the American Heart Association Scientific Sessions 2022 that just happened in Chicago. And first and foremost, as we're all getting through COVID and starting to meet people in person, it was really wonderful to see so many friends and colleagues and such a lot of interest at the meeting and some new signs that I'm going to share with you today. Shown in this slide are my disclosures. There are three papers that I really want to talk about today, but before we do that, I just want to highlight the fact that the American Heart Association 2022 was a hybrid congress. It was held in Chicago, as I just mentioned. It was also virtual. It was really good to attend a meeting and mix with colleagues, and it was great to catch up and discuss practice. And there's really no substitute to meeting people in person, but I really do like the hybrid format because many people who could only attend part of the meeting were actually able to, also attend other sessions that they actually missed in person. So there's a lot of good that has come out of these types of hybrid conferences as well. So let's get started. And the first paper I'd like to share with you today was presented as a featured science paper at the American Heart Association. I had the great honor of presenting and leading this analysis, which was also published in Circulation simultaneously. And this compared the outcomes in the Emperor pooled analyses of Black versus white patients in terms of their event rates and their efficacy and safety of empagliflozin in the context of Black patients enrolled from the Americas with heart failure. And let's, just take a bit of a quick dive into this paper. As many of you know, Black patients are underrepresented in clinical trials and experience disparities in rates of and outcomes of heart failure compared with white patients. While analyses from the DAPA-HF and the Emperor reduced trials demonstrated a consistent benefit of SGLT2 inhibitors in Black patients, data were limited to HFrEF and included a small number of Black patients. Now, the Emperor pooled study was really a prospectively designed pooled analyses. It had its own statistical analyses plan that was developed prior to both of these trials actually enrolling patients. And the Emperor reduced, as you know, was a trial of patients with heart failure and a reduced ejection fraction who received empagliflozin versus placebo. Emperor preserved was people with heart failure and an EF that was mildly reduced or preserved. So in total, there were 9,718 patients who were randomized across the spectrum of ejection fraction in the pooled analyses to empagliflozin or placebo. And the trial's primary outcome was the composite of first hospitalizations for heart failure or cardiovascular death. Now, we restricted the analyses here to Black patients and white patients in the Americas. And as you can see here in the next slide, of the 9,718 patients in the pooled analyses, 3,024 from the Americas were white and 478 were Black. Now, there were certain baseline characteristics that were different in Black patients compared to white patients. They seemed to have, they were younger, first and foremost. There were more women than men. They had a lower ejection fraction, higher rates of non-ischemic heart failure etiologies, a higher GFR, lower rates of atrial fibrillation, similar rates of diabetes, and also there were similar levels of NT-proBNP. And you're going to, you can read more about that in the Circulation paper. Now, the first message, really, colleagues, that I'd like to offer all of you listening today is that there continues to be a persistent risk in Black patients that is higher than white patients with respect to the primary endpoint of CV death and heart failure hospitalizations. You see here the hazard ratio is almost 1.5 times, 1.49 with a p-value that is highly statistically significant. And this reminds us that despite sort of all of our efforts at improving outcomes across the board, there are certain groups of patients, and in this case, Black patients, that continue to have this excessive, exaggerated risk of heart failure events. And this is a really important message for all of us, that we need to focus more on this population, understand it more, and therefore develop strategies that are safe and effective to reduce the risk in this population. Now, when we look at the primary endpoint in Black versus white patients in the Emperor pooled, now looking at the placebo event rates, first and foremost, as you can see here, were much higher in Black versus white patients in the Emperor pooled. In Emperor reduced, they were also significantly higher, but the difference was not that much higher in the Emperor preserved trial. So again, there are overall differences in the outcomes of CV death and heart failure that seem to be predominantly driven via an excess risk in people with a reduced ejection fraction. Now, let's also look further at the primary endpoint here, again, in the Emperor pooled, Emperor reduced, and Emperor preserved trials. And what you see here is a trend. First and foremost, you see a consistent benefit of empagliflozin, in Black and white patients. And the p-value for interaction in the pooled analyses is 0.08. So there seems to be a trend, which is hypotheses generating, of greater efficacy in Black patients in the Emperor pooled analyses, but that truly cannot be anything but hypotheses generating, because the p-value for interaction is not significant, and the numbers of patients in the Black group are also quite small. But when you then dig deeper and look at the Emperor reduced data set, here the p-value for interaction is statistically significant, again with the suggestion that Black patients with a reduced ejection fraction may derive a greater benefit from empagliflozin. Now, this is really important news, because many conventional therapies, such as ACE inhibitors, beta blockers, and others, have been shown to have a reduced efficacy in Black patients. And therefore, this analysis was important because we wanted to make sure that the efficacy was consistent in Black patients. And if there's a suggestion that there could be a greater relative risk reduction, that needs to be really evaluated prospectively. But what is really important is that because they're at higher risk, the absolute risk reductions are higher, and the number needed to treat is resultantly lower. And now let's just look at some of the safety outcomes. If you look at the placebo event rates for adverse events and serious adverse events. So I'm calling your attention to the placebo group on the right. You can see numerically there are more adverse events, 88.3 versus 83.6, and 61.5 versus 51.2 with respect to serious adverse events. So that tells us that Black versus white patients have greater adverse events in the placebo group. However, when you look at the empagliflozin group on the left, it's clear that the empagliflozin treated patients relative to the placebo treated patients who were either Black or white had no excess step up in these adverse events. So really there was comparable safety overall, and also comparable safety with respect to some of the key side effects, such as hypotension, symptomatic hypotension, volume depletion, genital infections, acute kidney injury, hypoglycemia between the two populations. So we concluded this analysis by reminding the attendees that Black versus white patients were at higher risk of heart failure events in the Emperor pooled analyses. The efficacy and safety profile of empagliflozin was similar in Black and white patients with heart failure when assessed irrespective of ejection fraction. The findings are limited by a relatively small number of Black patients, And I think most importantly, as I stressed at the meeting, it is really important, and I think an urgent an unmet need that we need to recruit more Black patients in future trials. The second paper that was presented by Professor Jawed Butt and Professor John McMurray and Professor Scott Solomon and colleagues. I was also a co-author on this abstract, and it was also presented at the featured science session entitled A Second Look at Practice-Changing Heart Failure Trials, and a similar approach of looking at dapagliflozin across the spectrum of ejection fraction in the DAPA-HF and DELIVER trials by Black versus white race. And so you can see that this is the second paper along the same lines of what I've just presented to you. So this examined the efficacy and safety of dapagliflozin versus placebo in Black and white patients from the Americas across the range of ejection fraction from DAPA-HF and DELIVER. And what you see here are many, many consistent observations similar to what I just shared with you in the Emperor pooled analyses. Black patients, there were 381 versus 2,626 white patients from the Americas. You see that they were younger, 64 versus 70, more women. And moving down the list, one point noted here that I'd like to emphasize is that in the DAPA-HF and DELIVER, the KCCQ scores were similar at baseline, and in the Emperor pooled analyses, we found that the KCCQ scores were lower in Black patients. They tend to be, numerically lower here as well, as you see 69 versus 64, and that just reminds us that actually Black patients are more symptomatic. Patient-reported outcomes are lower at baseline. The ejection fraction also lower, 39 versus 44, and the NT-proBNP levels were comparable. The GFR in this analysis tended to be lower. Similar numbers of people had diabetes. There was a significantly lower rate of atrial fibrillation and lower rate of myocardial infarction in the pooled DAPA-HF and DELIVER analyses. And here you see the primary outcome in Black versus white patients, first and foremost, emphasizing that Black patients in the pooled DAPA-HF and DELIVER analyses were at higher risk compared to white patients, and an entirely consistent benefit of dapagliflozin in Black versus white patients with heart failure across the spectrum of ejection fraction. Now, we could look at this in a different fashion, not just looking at the primary outcome of worsening heart failure or CV death, where you see a consistent benefit of dapagliflozin, but all of the outcomes, worsening heart failure, cardiovascular death, all-cause death, total heart failure hospitalizations, and CV death, all in favor of dapagliflozin with no heterogeneity in Black versus white patients enrolled. Now, another wonderful analysis that the group has done is looking really at the spectrum of ejection fraction. On the left, white patients, on the right, Black patients, and you see that across the continuous spectrum of EF from 15 through 75%, the line is actually a straight line. And I'm referring to the line within the pink shaded area of the slides. And that tells you that the hazard ratio is consistently below 1 in white and Black patients, irrespective of the baseline ejection fraction. So it's a really important message that consistency of dapagliflozin is seen in Black patients and white patients, and that there is really no sort of attenuation of this efficacy at any level of ejection fraction. Now, in terms of quality of life, now one of the other reasons why we treat patients with heart failure is to improve their symptoms. And we saw this as well in the Emperor pooled analyses, and you see this here as well in the pooled DAPA-HF and DELIVER analyses that there was an improvement in KCCQ total summary score from randomization to 8 months that was similar in Black and white patients. Now, in the Emperor pooled analyses, there tended to be a slightly greater improvement in the clinical summary score. But again, I think both of these are entirely consistent with each other, suggesting that SGLT2 inhibition with dapagliflozin or empagliflozin consistently improves morbidity and mortality outcomes and patient-reported outcomes in people with heart failure across the spectrum of ejection fraction. With respect to treatment discontinuations and adverse events, you see here, again, a very, very, very consistent and comparable side effect profile between the two groups. No excess step up. If you look at, for example, Black patients versus white patients for volume depletion side effects, you can see that they're very similar. Renal adverse events, numerically seem to be slightly higher in Black patients. No excess in amputation, no excess in major hypoglycemia. Discontinuation rates were sort of similar in Black and white patients, or in the white patients and Black patients. There tended to be sort of a numeric, but not statistically higher rate of discontinuation. And importantly, discontinuation due to an adverse event is similar in all of the groups, as you see here. So comparable safety profile in Black versus white patients is the key message here. So the authors concluded that dapagliflozin reduced the risk of worsening heart failure, CV death, and all-cause death across the range of ejection fraction to a similar extent in Black and white patients. It was safe, well-tolerated, irrespective of Black and white race, and therefore treatment of patients with proven therapies in high-risk populations can further reduce pre-existing healthcare disparities. Now, I really want to end by a translational randomized trial, again, that I presented as a featured science abstract at the AHA, and this was the primary results of the EMPA-HEART-2 CardioLink 7 randomized trial, which evaluated empagliflozin and cardiac remodeling in people without diabetes. In terms of background, again, as you know, the SGLT2 inhibitor field has been transformative from a prevention and a treatment standpoint for heart failure events. And we know that a lot has been written about in terms of how do these drugs work and how might they promote reverse cardiac remodeling. They indeed do promote cardiac reverse remodeling in people with diabetes or heart failure, but it has been theorized that these drugs may potentially be useful if introduced even earlier on in the natural history of heart failure in people who don't have diabetes or in people who don't have prevalent heart failure but may have risks for adverse cardiac remodeling, the so-called stage A or stage B patient. But this theory has really not been formally evaluated. And that's why we did the EMPA-HEART-2 CardioLink 7 trial to determine if empagliflozin would promote reverse remodeling in people without diabetes or without significant heart failure. So in terms of the design, adults without diabetes who had greater than or equal to 1 major criteria or greater than or equal to 2 minor criteria were enrolled. The major criteria tried to enroll people with elevated left ventricular mass or resistant hypertension, and the minor criteria included people with a prior history of myocardial infarction, a GFR between 30 and 60, and a BMI that was elevated. A baseline MRI was done, cardiac MRI, the gold standard, again, to evaluate left ventricular remodeling. People were randomized to empagliflozin versus placebo, and the primary outcome was a 6-month change in LV mass index to body surface area as measured by CMRI, and there were other measures looking at volumes and ejection fraction as well. The patient population that we enrolled was approximately 60 years of age, predominantly male with a BMI of 29. The LV mass index at baseline was 64 grams per meter square, and the majority of people had hypertension. And shown here are the change in cardiac parameters assessed by CMRI. And it's a bit of a busy slide. I just ask you to focus on the last column, which is the adjusted treatment difference from baseline to 6 months. And here you see that there was actually no difference in LV mass indices between the two groups over 6 months. The adjusted treatment difference was 0.3 grams per meter square, which was not statistically significant. And all of the other indices mentioned here, LV mass, end diastolic volume indices, and systolic volume indices, were not different. There was a intriguing trend towards a improvement in ejection fraction of 2%, as you see here. And, we have actually taken that information, pooled it with the EMPA-Heart-1 study, which was a study in a very similar sort of group of people who had diabetes and had coronary disease, but not heart failure. And we seem to find that the two trials put together point towards a 2% statistically significant increase in ejection fraction. Again, that's hypotheses generating and needs to be further teased out in prospective studies. In terms of some of the changes in clinical characteristics, nothing striking to report here. Really no major changes in blood pressure. There was an increase in hematocrit, as we expect with these agents, and there were no NT-proBNP levels were very low at baseline, reflective of the population we enrolled, and did not change appreciably with therapy. So what have we learned from this exercise? That empagliflozin is a wonderful drug we know for preventing heart failure in people with diabetes and treating people with HFrEF or HFpEF. But in terms of whether it can promote meaningful changes in LV structure or function at 6 months in people who are lower risk without diabetes or without appreciable heart failure, that is a question that we asked, and it seems that the answer to that is no, not within the time frame and the risk level of patients that we studied. So this does not in any way discount the fact that these drugs may not have other potential benefits outside of left ventricular remodeling, but that is not something that we study. So those are the 3 papers I wanted to share with you today. I hope you find them useful, and very much look forward to speaking with you in the future.